Well, I think the last several years have really witnessed a revolution for the management of atherosclerotic vascular disease. And there have been a number of novel therapies along different axes of risk, which have showed benefit. And that includes lipid risk, where we've seen different lipid lowering agents show benefit through LDL reduction, maybe through LP(a) reduction, although that is remaining to be seen in a prospective way. And things like icosapent ethyl. So there's more tools in our toolkit for lipid risk, antithrombotic risk. There certainly is more data now for ticagrelor from the Themis trial, building on Pegasus TIMI54. In addition, the landmark Compass trial and Voyager showing a benefit for dual pathway inhibition using a factor 10A inhibitor. So more evidence for antithrombotic therapies. We also see benefits for diabetes risk and with some novel agents, although initially studied for glucose lowering, the benefits appear target specific, and we see broad benefits for the GLP-1 agonists for ischemic outcomes and the SGLT2 inhibitors for heart failure and renal outcomes. And so broad benefits there as well. And I think it's been very exciting also to see the evidence behind inflammatory risk and that targeted therapies like canakinumab can do that. When that translates to the clinic is unknown, but we know we can modify that risk. So I think that's very exciting. What I think the future will be, of course, is one, risk stratification to understand which of these patients with atherosclerosis, because it's a big population, should get which therapy and when. How do you stage these therapies? And then, as others have coined the term of sort of not just primary prevention, but primordial prevention, the earlier institution of some of these therapies to actually prevent atherosclerosis rather than just to treat the complications in those that have it. I think that's on the horizon. Well, I think some of the cutting edge therapies are really those as sort of targeting different axes of risk, but in the lipid realm, obviously we were very comfortable with statins. Ezetimibe was proven to be efficacious in the Improve It trial, landmark trial showing a non-statin could achieve the same benefit per millimole reduction in LDL cholesterol. But now we have other therapies. We have the PCSK9 inhibitors, which are clearly efficacious and robustly reduce LDL cholesterol, bempedoic acid, icosapent ethyl. So several different axes of risk. There are also several on the horizon that are very exciting. There are inhibitors of LP(a) or antagonists of LP(a) or agents that will reduce that risk. There are agents targeted at reverse cholesterol transport. So recombinant human LCAT, endothelial lipase, other agents like that. We also have ANGPT3 and ApoC3, ApoC reducing agents. So I think there's much more work to be done in terms of lipid risk. But as we have more therapies, one of the important aspects will be to understand how to target those therapies. It's not going to be the same thing for every patient. In addition, there are novel diabetes agents and novel antithrombotics on the horizon, are the factor 11 inhibitors, which promise to reduce ischemic risk with a better safety profile. And there are more studies with antiplatelet agents trying to understand the best combination. And certainly the updated chronic coronary disease guidelines by the European Society of Cardiology really now start to focus on risk stratification and picking the highest risk patients who are at low risk for bleeding to tailor these therapies. So much on the horizon. I guess one additional note is the nuances in the types of antiplatelet therapies and the aspect of P2Y12 monotherapy for long-term prevention in patients with coronary disease, which may be a safer alternative to DAPT, and there's some promising data there as well. COVID-19 has had dramatic effects for all of us, whether or not you work in the scientific field or the medical field. I mean, it's of course affected everybody. But I think for those of us that see patients with vascular disease, there have been some specific impacts of this. First of all, we know that COVID-19 is a virus that not only is a respiratory virus, but it really is a vascular virus, that there's an endotheliolitis, there's a coagulopathy, maybe tissue factor dependent. And so that we see patients coming in with heightened blood clotting risk, and that manifests not only as venous thrombosis, but also arterial thrombosis. So heart attacks and strokes happening in patients with no history or no risk factors for that, and high incidence of pulmonary embolism and other complications. So as vascular practitioners, certainly the population is at heightened risk, and we're wondering how to best treat that, but our vascular patients are even higher risk for those complications. I think the other impact of the COVID pandemic is that patients and clinicians are delaying procedures, maybe doing visits in a virtual setting, which can be very effective. But nonetheless, we worry that there are patients that need procedures, patients having chest pain, patients having limb pain, that are delaying their presentation to the hospital or delaying calling their physician because they're afraid to come in because of COVID. And we've already seen some impacts of that, the patients coming with late stage problems where they would have been better treated early on. And so that's another feature of COVID that we're grappling with now. Well, as we exit 2020 and we look forward to 2021, certainly the rollout of effective vaccines is very exciting because it shows us a sort of light at the end of the tunnel, although I think we all recognize that may be a long tunnel in terms of actually moving the needle for COVID infections. Well, what does that mean? I think there's a wealth of data that's going to come out in terms of how to better treat patients with COVID, particularly some of the vascular complications, doses of heparin, use of antiplatelet therapies, novel anticoagulants like tissue factor inhibitors. There will be more and more data, I think, and those data actually will provide information beyond COVID. We'll understand better how to treat patients with viral-induced coagulopathy and maybe some analogous situations like the antiphospholipid antibody syndrome. And then I think as we exit the COVID pandemic in 2021, hopefully we can refocus some of the research efforts and clinical efforts on better treating our vascular patients and our patients with atherosclerosis. I think it's been an exhausting time, 2020, for everybody, but we can't sort of ignore or under-recognize the risk that our patients face. Even though they look stable, we know that they are at high risk, and we need to continue the push for more effective preventive strategies and ideally strategies that will prevent the incidence of atherosclerosis altogether.